I now have 2 o'clock, so I was going to go ahead and get started. So thank you all for coming today to today's webinar, Approaches to Centering Equity and Health Communication Research and Practice. My name is Tiffany Chavis, and I am the Outreach and Education Librarian for Region 1 of the NNLM located at the University of Maryland, Baltimore. I'm going to be your host for today's session. Okay, so not everyone is familiar with the NNLM, so let me tell you all a little bit about us. We are the network of the National Library of Medicine. The NNLM is funded by the National Library of Medicine, which is the world's largest biomedical library, and the NNLM is the outreach arm of the National Library of Medicine. The NLM is a part of the National Institutes of Health, which is the nation's leading research agency. The NNLM has what we call ROCs, or regions, offices, and centers, and it's made up of 7 regional medical libraries, 1 here at University of Maryland, Baltimore, 4 national information centers, and 3 national offices. They all provide training, funding, and engagement opportunities to over 9,000 NNLM member organizations. If you would like to learn more about the NNLM, or if you would like to learn more about membership, individual or organizations, you can go to our website at nnlm.gov. And finally, now let me introduce to you our speakers for today. Both of today's speakers are from CommunicateHealth in Rockville, Maryland, which is a suburb of DC, to give a little context. The mission of CommunicateHealth is to improve lives by designing health information that is easy to understand and use. Today we have with us Sandy Hilfiker, who is a CEO of CommunicateHealth. And we also have Jaime Dawson, who is the Senior Project Director and NIH Portfolio Director for CommunicateHealth. Welcome to both of you, and thank you so much for joining us today.
Thanks, Tiffany, and appreciate the introduction, and also thank you for organizing the panel today. Well, welcome everyone to our webinar. As Tiffany said, this is called Approaches to Centering Equity in Health Communication Research and Practice. And Tiffany said a little bit about CommunicateHealth, where Jaime and I work, but just a little bit more before we get started. We're a women-owned, LGBTQ+ owned small business, and we focus on developing health information, products, and campaigns that are clear and inclusive. And you know, we support clients from federal clients like National Library of Medicine to state and local health departments to nonprofits, and also some private health organizations as well. As Tiffany mentioned, I'm the CEO at CommunicateHealth, and I've been working in the field of communication and health literacy for over 20 years. I spent my career making complex health systems, products, and information easier to understand, access, and use. And I'm really excited to be here today and to talk about our equity-centered health communication framework and some practical examples of how we apply that framework in our work. And I will turn over to Jaime to introduce herself.
Hi everyone, I'm Jaime Dawson. I'm a Senior Project Director, and I have over 17 years of experience working on health communication initiatives, including on behalf of some national healthcare associations. And in my current role at CommunicateHealth, I oversee a large portfolio of projects and lead teams to create digital and print materials. And we prioritize plain language, health literacy, and health equity. All right. And here we are. Okay, so we'll start our conversation today by defining health equity and reflecting on how we are at a crossroads in health communication. We'll share an overview of an equity-centered health communication framework with a focus on research, design, and strategy. And we'll also walk through some case studies of incorporating the principles of the framework into developing inclusive health materials, digital products, and campaigns. And we'll share some case studies specific to the work and mission of NNLM. So here are our learning objectives for today. So at the end of the webinar, you all will be able to describe the phases of the equity-centered health communication frameworks framework, and also understand the characteristics of inclusive health communication products. And finally, naming strategies for developing more equitable and inclusive health communication materials and products.
All right, great. Thanks, Jamie. So throughout our presentation, obviously it's a little bit hard to be super interactive on, in this kind of format and with limited time. But throughout our presentation, we'll have some opportunities for you to engage, either by asking you to contribute to a question or answer a question in the chat, or we'll be putting in some polls and word clouds into the chat for you to answer. So we're going to start with that just to break the ice. So the first one is going to be a word cloud, and I'm going to put the link into the chat. So if you just go to that link, you're going to type in the state that you're calling in from, and then you should be able to see in real time in that link where everybody is coming from. And the states that have more representation will get bigger on the screen. Great. So I'm seeing representation from lots and lots of states, and looks like the most folks are from the states of New York, Ohio, Maryland. We've got a lot of people from Texas, Georgia, so all over the place, which is great. So we have huge representation. You can see at the bottom of that how many people have voted for different states. So people from all over the country, which is really cool. Okay, so we're going to move on to one more question just to get to know who's here in the room virtually. So I'll give you that link. Okay, back in the chat. Okay, so this one is going to be for you to put in what organization you work for, and there's a number of choices. There may not be every choice, so if yours is not there, just answer other. Great. So lots of different types of organizations represented here today. Looks like the most, oh, I don't have, oh, I see somebody can't access the link. But thank you for putting it in the chat. Sorry about that. We have a lot of people so the choices, if you couldn't access the link, we have folks from healthcare, facilities or hospitals, health organizations, libraries, university or other research institutions, state and local health departments, community organizations, federal government, and folks from a variety of other places too that are not represented in the list. So great. Well, thanks for doing that. We'll have a few more of these as we go. And just before I turn it over to Jamie, I want to make sure you feel free to ask questions in the chat as we go. We're happy to pause. We'll be monitoring that and we can answer questions, but we'll also have time for questions at the end as well. So I will turn it over to Jamie.
Thanks, Sandy. All right, so let's get started today with a definition of health equity. And we like CDC's definition that health equity is the state in which everyone has a fair and just opportunity to attain their highest level of health. Now, the terms equality and equity are often used interchangeably, but there are some really important differences. The Robert Wood Johnson Foundation followed a human-centered design process to show the difference between equality and equity. And this graphic on the screen shows the interplay between individuals and their environments. So on the left here, you'll see a diverse group of people crossing a street. This represents equality. Everyone here is experiencing the exact same conditions and environment while they're crossing the street, regardless of what they need to do that safely. And then the image on the right represents equity. And here the environment has been adjusted to meet everyone's individual needs in crossing the street. So you'll see a curb cut for the person in the wheelchair, and audio cues for the person with a visual impairment. Here, everyone has what they need. We really are at a crossroads in health communication, and the COVID-19 pandemic brought to light some long-standing inequities. During the pandemic, Black, Hispanic, Latino, and Indigenous populations experienced higher rates of COVID-19 infections, hospitalizations, and also deaths. And this is a result of some really complex social, economic, and healthcare factors, like lack of access and discrimination in the healthcare system. And these factors have contributed to worse outcomes for members of these populations. And health communication can worsen inequities, or it can start to close gaps in access and understanding. And as health communicators, we can close these gaps by making sure information and resources are accessible, understandable, and culturally relevant for the audiences we're serving. I want to do another word cloud activity and ask you all how your organization advances health equity. Sandy's going to share the link. And we'll give you all a little time since this is a very reflective question. And the question again was, how does your organization advance health equity?
Saying a lot of different answers here. Big one is education, but there's everything from research to DEI initiatives. I saw somebody at one point wrote listening, which is great.
Yes, I still see lots of people typing. So keep going if you're typing, and we can revisit this as we're going through the presentation. Yeah, lots of great ideas here. Education, policy, research, community outreach, social determinants of health. All right. Wanted to reflect a little bit on the role of libraries in health equity. We know that libraries have a very important role because libraries have an extensive reach. Found a really interesting data point that you all might already know, but that according to the Public Library Service Poll, 96% of the US population live in a public library service area. And more than half the people in the US have visited a library in the last year, which is a pretty impressive statistic. And we know that libraries are safe and trusted spaces and serve populations of people who are most impacted by health inequities. In addition to offering access to reliable information, libraries offer important social services like connecting people to housing, food, and some other public aid programs. And we're highlighting libraries as an example here, but clearly see that you all represent a diverse range of organizations. And we'd encourage you all to continue answering this question or also share, more narrative in the chat about how your organization advances health equity. We'd love to hear from you. And next, I'll turn it over to Sandy to start talking through the equity-centered health communication framework.
Thanks, Jamie. So as we mentioned in the introduction, the focus at Communicate Health, where we work, has been to create health information that is easy to access, understand, and use. And in other words, our focus has really been on health literacy, or how can we as health communicators decrease the mismatch between the skills and abilities of our audiences with the demands of often very complex health information. Over time, our thinking about health literacy, both at Communicate Health and as a field, has evolved. And now we focus much less on the individual in terms of increasing their skill set or thinking about their health literacy levels, to looking almost solely at the issues with the system. This also is how we look at advancing health equity as well. It's not just simply that people can't read and understand health information very well. It's that we create barriers to understanding by creating overly complex systems, products, and information. And I use the collective we. I know people in this room are working hard to do the opposite. We found that if we make equity an intentional foundation of our work, a lot of other changes flow from there, including changes to how we practice health communication, how we design campaigns, materials, how we conduct research, and how we build websites. So we decided to formalize this intention by creating the Equity-Centered Health Communication Framework, or ECHC for short, because everything has to have an acronym, of course. Next slide. To develop this framework, we started with a couple of foundational models. These are just a couple. There were several that we looked at that we've used over the years to guide our work. The model you see on the left is in what's called the Pink Book. Literally because the book was pink, and it's actually called Making Health Communications Work, and actually was first published way back in 1989 by the National Cancer Institute. And I actually saw on this, sorry, there's some kind of presidential alert coming through my phone. Sorry about that.
Federal emergency alert for everybody in the country.
Okay, great. Sorry about that. But I actually saw on this webinar that Gary Krebs is here, who actually, I think, wrote a lot of the Pink Book. So that guide, still stands the test of time, and, has a lot of the phases of the health communication lifecycle that we follow. We also borrowed from the human-centered design framework or model, which is what you see on the left. And HCD is mostly centered around the digital product development process, but really, is about iterative design, refining, testing, updating. And though it's mostly focused on the digital product development lifecycle, so it has some limitations for broader health communication efforts. The reality was that in the current state, the frameworks that we were using and the methodologies weren't enough to counter legacy and present day systems of health inequities. So, though there was a lot out there, we thought even small shifts to how we practice health communication could go a long way toward rebuilding trust and disrupting the power imbalances at the root of health inequities. So this is where we landed, which I think, we put this out just this year, so it's probably a work in progress. But we see this framework as both a process and also a shift in mindset. So this model is really all about creating space. So you'll see we took the plan, implement, evaluate cycle from the Pink Book and tweaked it to make more space for participation. And we also included 3 phases really based on the human-centered design model, the understand, co-create, and implement, but made them more iterative to create more space for continued learning. And then we defined our ideal outcomes, which is what you see right there in the center of the framework. If you go to the next slide. Our ultimate goal is to create communications that are clear, or in other words, are they easy to understand and use? Relatable, which just means do they reflect the lived experiences of our audiences so that people can see themselves in the communication? Actionable, or is the information easy to act on so our audiences can take care of their health and keep their families safe? And finally, inclusive. Do the resources meet the needs of as many people as possible in as many circumstances as possible? The idea here is to help us shift power, including who has power to identify the problems and the solutions to drive change. So this looks like shifts in our approaches and methods. For example, taking the time to involve community experts up front in our research and development process, or could just mean simply changing the way we collect demographic data. And then there's also shifts to our thinking. For example, developing an understanding among our internal teams of the root causes of inequities, Or this could look like developing an awareness of who is at the table and who's not. So just to dive in, and let me pause and see. Okay, yes, the FEMA alert. Hopefully we've moved on from there. So just to dive in on phase one, which is understand, we're going to go through kind of each phase high level and then talk about some practical examples. Before I dive in or while I start talking about the next piece, please put in the chat some of the strategies you've used to better understand the audiences and communities that you serve. So if you could start putting some ideas in the chat there about how you better understand your audiences, I'll keep moving and then we'll revisit what's in the chat. All right, so the first part of the understand phase is to define. And at this stage, we're really defining the problem we're trying to solve, and we really need the community's help to do this. One thing we have shifted our thinking around is that we want to consider our framing. So instead of approaching this from a deficit-based approach, like this community has a disparity or they have this problem and we need to help fix it or correct it, we want to look at, when we can, a strengths-based lens. So focusing on the cultural and community-based strengths and assets, which Jamie's going to talk a little bit about an example of this later. When we approach this step from an equity perspective, we're also looking at power dynamics, both historical and present day. And we want to move beyond just behavioral determinants of health, so thinking about the individual, to structural drivers. Next slide. Audience segmentation, which is part of this phase, is really critical to an equity-centered approach. And it's always been critical to health communication, but so often this step gets skipped. Our clients often start out by telling us that their audience is the general public. And we know the general public is not an audience. So we really need to go further to understand the nuances of the audiences we're trying to reach. This is where we want to go beyond basic demographic data to better understand our audience and how to reach them. We might look at attitudes, beliefs, and information preferences. We also want to be mindful of intersectionality and the messiness of identity. There's tons of diversity within audience segments and also across. So often the within diversity is not accounted for. And acknowledging this fact goes a long way to helping people feel seen and heard. Okay, so just looking in here, lots of great ideas of ways, focus groups, community health fairs, doing outreach, listening. This is great. We're going to talk about a little bit more of this in just a second. So I'm going to do one more word cloud here. In the chat. If you want to type in here, just to make this a point about intersectionality, what are some examples of social and political identities? And feel free to name as many as you can. I think we'll find that there are many, many different ways that you can either answer your own identities or identities that of the audiences you serve. Yes. So many times I think we just approached it from just gender or race potentially, maybe age, but we're not thinking about lots of these other identities as well, which matter in terms of what messages are going to resonate and how we reach our audience. I can see lots going in the chat and in the, great. All right, next slide. So, maybe most importantly in the understand phase is to empathize. And this is when we connect with and learn from our audience. So all those things you chatted about a little bit earlier that you do to better understand your audience, this is what needs to happen in the empathize stage. This might look like formative research, like focus groups, interviews. It could be social listening, engaging community experts, participating in, like you said, community health fairs and other things. And to do this work, we need both empathy, which really means to listen, and humility. And that means to acknowledge our gaps in understanding and our own biases. And I know that, for me personally and how we think about this as as a team is that I know who I am shapes how I approach my work. And I think this is something that has not been talked about traditionally in the communication science space. And I want to, so one of the ways that I think about this is making sure there's people in the room, whether it be audience members or, community organizations that we're working with, or just people on my own team that are going to be there to check my assumptions and challenge my biases. And then finally here, you can see the arrows within this phase, indicate that oftentimes once we do this work of defining, segmenting, listening, empathizing, our original understanding of the problem has likely changed. And that's a good thing. That means that we're going to be more effective, that we're going to understand what our audience really needs. So now I'm going to turn over to Jaime to provide an example of what this looks like.
Next, we want to highlight the Live to the Beat campaign, and this is an initiative developed by the CDC Foundation and several partners, including CommunicateHealth and Majority, a Black-owned creative agency. This campaign aims to increase awareness and motivate behavior change in Black adults ages 35 to 54 who are at risk for cardiovascular disease, or CVD. And this campaign has a lot of different products, including a great website, interactive online tools, and several videos. So connecting back to the framework that Sandy just walked through, we began by defining the focus of the campaign and segmenting our audience. And we really wanted to start by reflecting on what we can change and what we couldn't change through health communication. We decided on educating people about CVD risk factors that they have some control over, even though there are external factors and social issues that impact heart disease disparities. We focused on adults ages 35 to 54 because this age is most likely to benefit from preventative measures. This campaign really was grounded in empathy and deep listening. We planned 3 rounds of research with Black adults who have at least one heart disease risk factor. This included 30 discussion groups, all led by Black moderators, with a total of 150 participants. The audience helped direct key decisions about theoretical constructs that we ended up using, campaign messages, and the overall tone of the campaign. And it was important for us to recognize the diversity and intersectionality among the priority audience. We looked at our research findings and created personas that I'll show you in a minute. This helped our creative teams make content that would be meaningful to everyone and not use stereotypes or cliches. So this is the extended parallel processing model. There's a lot on this slide, and I'll keep it pretty high level. We use this model, which says that the key to desired health behaviors is a delicate balance between perceived threat and efficacy. And from our research, we found that the majority of our audience fell within this high threat, low efficacy section, which is indicated by the star. In general, this audience was really aware of their personal CVD risk, so they had high knowledge, but they didn't feel equipped to address it or fix it, so they had low self-efficacy. The strategy in this case is to educate the audience with solutions and to build confidence in their ability to prevent CVD. And we grouped our findings from research and developed 4 personas using these audience characteristics and things like perceived motivators, level of threat, and self-efficacy. And I'm going to show you 2 examples. So this first persona is Overbooked Angela, who represents the majority in the matrix, with high perceived threat and low perceived efficacy. And Angela has high perceived threat because a member of her family experienced a severe stroke. And she also has competing priorities. She's busy, and that impacts her ability to make a change in her daily life. So in order to reach someone like Angela, we would share time-saving tips for lifestyle changes that work with her schedule. We would remind her that small steps add up and it's never too late to make a change. And we'd empathize with her competing priorities by telling her that self-care will not only help her, but help others. And next, this is Doubtful Daryl, somebody who has a perceived low threat and high efficacy. So Daryl doesn't think he's at risk, but he thinks that if he were, he could easily control that risk. So our strategy here would be to educate Daryl about risk and emphasize the importance of prevention. And we want to make connections to things like improving quality of life and making sure he has some easy tips to implement. And so while Daryl and Angela are fictional characters, creating this persona really helped connect us back to that theoretical framework and helped us to empathize with and better understand the needs of our audience. And this helped us ultimately to create tailored and culturally relevant campaign materials. I'll turn it back to Sandy to get back into the framework.
Thanks, Jaime. So moving along in our framework, so there's kind of this connective thread that goes between the phases. So here we have plan, and I'm not going to spend a lot of time on the transition phases in the model, but before we're jumping into co-create, it's time to do some planning. And of course, planning is not confined to a single step in the communication process. However, once you have a clearer picture of the problem and the priority audiences affected by the problem, it's a good time to set your communication goals and objectives. And one trap, I think we often fall into is doing a lot of planning before we do our work in our understand phase, which often leads us down a path that isn't super effective or inclusive. So we go ahead and lay everything out, and then we go talk to audiences, which closes us off to potential redefining of the problem and finding a solution that will really work. So during this step, you're going to set realistic goals and objectives, and most importantly, plan how you will include members of the community in your process. I'll talk about this a little bit later, but at this point, you have to really start identifying your partners and start to include them in each phase of your planning process. So next slide. So phase 2 is called co-create. And in this phase, we begin moving from planning and discovery to tangible intervention design. Whether it's a full-scale communication campaign or some new digital content, the basic steps of the co-creation phase are the same. They include ideating approaches, developing creative and message concepts, pre-testing the concepts with community members or audience members, building accessible products, and then learning and refining. Go to the next slide. So in an equity-centered approach, we have to question whether best practices, as effective as they may be, are enough. So we can't just rely only on best practices. That's a good starting point, but we also have to question, do they actually solve the problem? And do they solve it for the communities most impacted? Ideating is a time to create choices and generate ideas, and it's not the time to make a choice. It's a time to really think about all the options on the table. Here's some questions to drive iteration on potential solutions that you might consider. How do your own interests and expertise impact the type of ideas proposed? This is just you checking your biases and your assumptions. Will your solution be enough? Will it really solve the problem? What constraints are you assuming? What new ideas arise if you remove those constraints? So the next step in this phase is really to start to create some message concepts or creative concepts. And these are ideas and directions, not final products. This may look like a draft messages, a storyboard of a video idea, an early draft of a material, maybe a clickable wireframe of a website. So once you've got something to test, you're ready to do that and start to get early feedback. You want to do this while we talk about this at the concept phase early, so you have not gone too far down a path or spent too much money on something that you end up testing and it not being a good solution. So at this step, it's important to recruit and test concepts with diverse members of your priority audience. Take extra steps to recruit participants who are likely to have limited health literacy skills, maybe people who don't have access to broadband internet. My parents live in rural Kentucky and they have satellite internet and lots of things don't work for them. And also think about situational or permanent disabilities. Consider partnering with community organizations who work directly with your audience. And many of you here may be that organization that's working directly with your audience. So you have access to help identify and recruit people to give you feedback. During concept testing, you'll want to ask questions that help you determine things like, is this culturally appropriate? Is it clear? Is it persuasive if in fact behavior change is your goal? Is it useful? Is it credible? We know trust is a big thing we have to think about right now. And then finally, is it relatable? And just remember that testing doesn't have to be super expensive or with lots of participants. In fact, when doing usability testing of a digital prototype, just 5 participants can reveal over 85% of usability issues. So just remember that some feedback is always better than none. I know obviously big studies and lots of participants are always great to have, but we want to make sure that this can all be scaled to your budget, your timeline, getting feedback wherever you can. Now that you've gotten feedback on your concepts, you're ready to start really drafting and building out materials or prototypes, campaign creative. And the goal is to create products that help people access, understand, and use health information. So this includes addressing things like physical, digital, and content-related barriers to participation. And this is where you can lean on some of your best practices to help guide you, along with all that audience feedback you got. So your best practices in plain language, visual design, usability. So now with that, I'm going to hand it over to Jaime so she can talk about another example.
Thanks, Sandy. Well, we partnered with CDC and RTI International to create a suite of COVID-19 resources for people with intellectual and developmental disabilities. We wanted to prioritize co-creation every step of the way to effectively serve this audience. And for some context, intellectual and developmental disabilities, or IDD for short, are conditions that affect a person's ability to learn, move, speak, interact, or take care of themselves. And 1 in 10 adults in the United States has an intellectual or developmental disability. So examples might include Down syndrome, Fragile X syndrome, autism, and cerebral palsy. As part of this campaign, we created resources to educate adults with IDD about COVID-19 mitigation strategies, things like getting vaccinated, wearing a mask, taking a COVID test. Our materials featured illustrated characters shown on this screen who represent the diversity of people with IDD. On the right here are a few examples of our main characters. Alice is a young woman who has autism, Izzy is an older woman with Down syndrome, and Sam is a young man with fetal alcohol spectrum disorder. And after we developed the draft materials, RTI conducted interviews to gather feedback on our materials from adults with IDD and their caregivers. When we first started developing these materials right around the time of the COVID-19 vaccine rollout, we created resources about social distancing. And based on a literature scan of existing research about this audience, we knew that some people with IDD might struggle to process numbers. So we weren't exactly sure how to communicate the idea of staying 6 feet apart, which was a common call to action at that time, as I'm sure we all remember. And we'd originally placed a couch between 2 characters to illustrate the idea of staying 6 feet apart. And this might sound a little odd, but a typical couch is about 6 feet long, so we thought that that would be a good starting point. But when we tested materials with our audience, participants didn't understand the significance of the couch. The couch wasn't communicating the intended meaning, so we took it out and we went back to the drawing board on how to illustrate social distancing. And at that time, it was really common to see social distancing markers on the floor of grocery stores, doctors' offices, and other public spaces. So we use these markers in scenes where people might realistically see them. The scene on the top shows our main character, Alice, keeping a safe distance by following social distancing markers at the bus stop. And in places where it wouldn't be as realistic to show social distancing markers, like the scene at this park, Alice just keeps her distance from the other characters. And so connecting this back to the co-create phase of the model, we started with a concept, the couch, to communicate a really important public health message. And we tested this concept with audiences and realized that we needed to pivot. So we refined our approach and we settled on different imagery to represent social distancing. And with that, I'll hand it back to Sandy to talk about the next phase.
And I do want to just say, I think that is a great example, but also to not be afraid to include people that I think have been very traditionally not represented in any research, but in communication research, people that may have different disabilities. Also, we did a study recently with people with ALS who, have to use a lot of different assistive technologies. It's really important, even though it's a little bit more difficult potentially to do the recruitment or may have some more logistical types of considerations, you learn so much. Okay, so we're transitioning to our final phase, which is implement. And this is where we're strategizing. So, health communication is all about reaching the right people with the right message at the right time. And this strategy stage is when you really plan or add to your plan to do exactly that. So it's time for you to consider who your trusted messengers and ambassadors are, what channels are you using, when's the right time to reach your audience and how many times you need to reach them, and also how are you going to determine success. So in the chat, please chat some of the trusted messengers or ambassadors of the audiences that you serve, just as an example of things that we need to consider in this phase. And I'll come back to that as you all are doing that. Next slide. All right, so we're in phase 3, which is the final phase we're going to discuss, and that is implementation. And regardless of the size or scope of your health communication intervention, and like I said, this is very scalable. It can feel like a lot of things, but you can make this smaller and do this as developing a couple of health materials, or this could be the same process you follow for a multi-million-dollar campaign. So regardless of size or scope, successful implementation requires effective management, strong partnerships, and frequent communication. So this phase involves building diverse networks to help disseminate your message, creating opportunities to assess impact as you go, and then circling back to optimize your approach, sometimes in real time. So, we never get it right immediately. There's always iterations. And I'm seeing people in the chat just talking about folks that they work with or use as a trusted community, like community-based organizations, patients' rights groups, church leaders, civic leaders, family, health educators, local musicians, journalists. So these are all great examples. So in terms of dissemination, oftentimes we'll disseminate our messages, materials, or products through channels that aren't going to effectively reach our audience. We have oftentimes our clients will want to use their social media channels that don't actually reach the audience. Maybe they reach a professional audience, but don't really have a lot of wide appeal to members of the public, for example. Also, we have to think about what channels and sources have a high degree of trust. So this is where your partnerships do come in, and all of those people that you're mentioning, who does the community look to? Who do they trust? You working with those folks can help you build credibility and broaden your reach. So for effective dissemination, you want to build relationships and enlist community members, including influencers, relatable peers, early adopters. So all of those people you're starting to mention in the chat. And just keep in mind that during times of stress, people are often more likely to take advice from a familiar or trusted source. And I think we learned this painfully so during COVID about who people were listening to and were willing to take advice from. As you build partnerships, ask yourself questions like, how are you elevating the voices of community partners and experts with lived experience? Are you centering the community's priorities over your own, which can sometimes be challenging, especially if you're working for a funding organization who has really clear priorities? How can you leverage the strengths and specific expertise of each partner? I also want to note that the best partnerships are really built over time, and there has to be a lot of trust and buy-in involved. And you also obviously want to start this early. You're not starting that process later at this phase. Remember I mentioned at the beginning, you want to start engaging your partners way back when you start doing your planning. And then finally, assess. This final step in the phase is really about assessing how you're doing in real time. So we're not going to talk about evaluation, which is another one of those transition phases. But while you're disseminating whatever it is, your campaign or product, you want to be evaluating how you're doing. So on this slide are a few questions you might be asking yourself in this assessment phase that you can look at through different kinds of questions like analytics and other ways to gather some of this feedback. It's also a great time to consider developing a process for regular equity checks. So a couple of questions you might ask yourself in an equity check are, how are you sharing meaningful process data with affected community members? I think we often forget to share our evaluation or our assessment with the community that we're serving, and at the very least, the partnerships we're using are the partners we're engaging with. Also, does your data collection and analysis enable you to capture experiences of people with overlapping identities and compounded experiences? So can you look at not just how are Black women responding to your messages, but how are Black bisexual women responding? It depends on what matters, but looking at those combinations like we talked about with the intersectionality. And then with that, I'm going to turn over to Jaime for our last case study.
Yes, for this final case study, we're going to highlight the I Health, My Health campaign, which is a campaign we created with the National Eye Institute. Our priority audience for this campaign was African American adults, And our goal was to build knowledge, challenge social norms, and address specific barriers to eye health care. So connecting this back to the implement phase of the framework, we launched a campaign that was built on formative research with a lot of listening, a lot of conversation with our priority audience. We shared campaign materials through a network of NEI's partners, the National Eye Health Education Program, and we launched these initial products during Black History Month. So this included things like social media messages and fact sheets with a goal of empowering this audience to understand their eye health history, to make appointments with their eye doctors, and to encourage healthy habits. And one of our main messages here was to make the connection between eye health and whole body health. So for example, eating foods like leafy greens not only reduces the chance for diabetes, but also improves eye health. We developed a pilot to dig deeper and to make sure we were directly involving communities in creating this campaign. Our goal was to assess materials and the process that we used so we could refine them to help NEI launch the project, the campaign nationally. And here's what we learned from the pilot. We gained a deeper understanding of our audiences, their information needs, their communication preferences. We partnered with a company or a community organization, Common Ground Health, based in New York. During this pilot, they provided some really valuable insights and feedback to help us develop and revise campaign materials. They conducted educational sessions, community engagement activities with over 400 members of the community. And during these sessions, we were able to get direct feedback from the primary audience about the pilot activities. Attendees reported that they felt more engaged in eye health behaviors, such as healthy eating, getting dilated eye exams, discussing health history with their families. And this gave us a direct opportunity to test those campaign materials I mentioned. And participants shared that they found that these resources were engaging, informative, and interesting. And so based on this research and evaluation, we provided recommendations to optimize engagement with this community moving forward. This included partnering with trusted community organizations and creating culturally appropriate materials that had actionable steps. And of course, making sure our priority audience was involved in evaluation efforts. We want to share some additional resources before we finish up today. And this one is the health literacy framework. Communicate Health worked with the NNLM All of Us Program Center and the University of Pittsburgh Health Sciences Library System to develop this health literacy framework. And this is a reference tool that we use to understand the key factors that influence individual and organizational ability to access, understand, and use health information. This framework names the key factors that influence an individual's health literacy, their ability to understand and use health information. There are a lot of factors that influence someone's health literacy, and the variety of ways that these factors interact or overlap are represented here. You can find this framework on allofus.nnlm.gov, and Sandy's going to drop the link in the chat. And we're currently working to update this after multiple rounds of user testing, and we'll be launching an interactive version of the framework too.
One additional resource we thought you all might be interested in, speaking back to some of the best practices that you can lean on when developing your content or materials, is National Library of Medicine's HEMAT, or their Health Education Material Assessment Tool. So we worked with NLM to develop this tool over the last few years, and it's available also on NLM's website, which I will put that in the chat too. Along with a number of other health literacy resources. And, we did a lot of work on looking across other tools and a lot of work with SMEs. And we also did a lot of material testing. This is a really cool project to really speak with audience members and participants for them to evaluate materials and see, as we try to refine best practices, what things made the biggest difference in terms of people's understanding of the material. If you go to the next slide. So this is an assessment tool that can also be used as a guide to help you as you're developing materials. So it's really easy to use, and you can assess your English and Spanish materials for best practices and clear communication, or simply use the items in the tool as a guide for developing your materials.
All right, and before we move to Q&A, wanted to do a quick recap of our learning objectives. Won't read them again, but hopefully we touched on all of these and provided some good resources for all of you to reference. And let's see. And here are some of the references for the data points and the information I shared about libraries as partners in health literacy. We also want to make sure you have a direct link to the equity-centered health communication framework, and Sandy is sharing that here. Great, thanks, Sandy. And finally, we can move on to Q&A. So feel free to drop any questions you have in the chat, and we'll be happy to answer them. Sandy, you see this first one. How is HEMAT different, complementary to PMAT?
We actually built the HEMAT, we started with the PMAT to develop this. So NLM wanted something that was a little bit more, a little quicker and easier to use. Particularly they're evaluating all the resources that go on Medline Plus using this tool in terms of like their consumer materials or their Start Here materials. And so we used the PMAT and then did a lot of testing to figure out which items from the PMAT actually drove understandability the most. So we kind of whittled down the PMAT a little bit and then added more nuance and clarity about what each of those items looks like in practice. So a little bit more operationalization. And we also added some things that weren't as clear in the PMAT, like we added more nuance around numeracy, around use of images, and a few other things. So you'll see if you compare the two, there is a lot of similarities. The HEMAT's just a little bit, I would say, scaled down to your biggest bang for the buck items with a little bit more nuance around what it looks like to do that item in a material. And there's also the Spanish version as well.
Yeah, and a follow-up comment. I like the PMAT because it does have the section on actionability.
Yeah, I think because a lot of the resources that they use with NLM don't always have a behavior change component, they emphasize that a little bit less. But definitely, we also really like the CDC Health Clear Communication Index. If you're not familiar with that, we can also put that in the chat. That is a great one in terms of behavior change items, risk communication section. So I really like that tool as well as an assessment tool for clear communication. All of these have their different strengths and weaknesses, but I think CDC Index is good for behavior change materials in particular.
I added that to the chat.
Okay, great.
And then how do you identify your key audience's status within the EPPM?
In terms of status, you mean kind of their identities, or make sure I understand what you mean by status.
Where they fall in the matrix. And which tool is this referring to? Oh, the extended parallel processing model.
Oh. Okay. That back to what we used on the Lift the Beat campaign.
Yes, I can go back to that quickly.
Yeah. So for this, we really let the research guide us to what theory or framework we want to use. And this is what we started to tease out from the focus groups. So basically what we did is take lots and lots of focus group data and then look at the characteristics of the different types of responses and participants and start to whittle that down into this matrix. So that was what drove this. In terms of identifying audience, when we put it out, we didn't necessarily know, which audience, but what we did is we developed materials, messages, products that addressed all of these 4 items so that we were getting, to how people were coming at it. So we had a whole series of messages, for each of these quadrants. Like on the website content, we tried to provide different kind of framing and pass for the different quadrants. So, we didn't necessarily know when we're putting out those messages. And I will say, we did not do the dissemination of this campaign. Jamie mentioned a company called Majority, which is an amazing creative firm and communication company did that piece. But this was really to drive how we crafted the messages and materials to address each of these items.
Yeah, thank you for that question. Any other questions? And thank you for that. All right, well, we can share one more resource. Get back to this. I'll share the link to the We Heart Health Literacy blog newsletter that we have. That is a great way to subscribe to current trends, tips related to health literacy. This comes out weekly, and I hope you all take a look.
Yeah, they're super short and actionable and written in a very fun way. So if you're interested in health literacy tips, this comes out every Thursday.
I'm actually a subscriber, and I enjoy reading it.
Thank you, Tiffany.
So last call for questions. We're about done here. Want to try and stay on track. We already put the link to get your CE or CHES credit in the chat, so you should be able to do that now. And again, I want to thank Sandy and Jamie for joining us today, and thank you for a wonderful presentation. And I hope you all enjoyed today's presentation, and we hope to see you all again soon.
Thanks for watching. This video was produced by the network of the National Library of Medicine. Select the circular channel icon to subscribe to our channel, or select a video thumbnail to watch another video from the channel.